Tonight I want to continue our series about medical education. Thus far, what we've covered is what we in the business call undergraduate medical education. That's a hard term to get your arms around because the people who are in it are not undergraduates in the traditional sense. They're people who have graduated from college and are then doing an additional 4 years of technically postgraduate work, but in medical school. But because it's the beginning of their medical education, we use the term undergraduate medical education. And after that comes the more apprentice part of learning, which is residency and fellowship, and I'll describe those. And then for the rest of your life, after you've done 4 years of medical school and 3 to 7 years or so of postgraduate residency and fellowship training, then you have the rest of your life to figure out how to keep up with things. And that we call continuing medical education, and increasingly as we do it in conjunction with the other health professions, we call it continuing health professions education, or now increasingly continuing professional development. And I'll talk about all those things and how it impacts medical licensing, board certification, and things like that. So just to frame the context a little bit, the sequencing, everyone goes to medical schools. As you know, in the United States, most medical schools are what we call allopathic medical schools, or some would say traditional medical schools. But medical school can also refer to osteopathic medical schools, and the growth in the medical students over the course of the last decade or so has occurred both with traditional medical schools expanding the number of medical students, the creation of several new allopathic medical schools, and a fairly dramatic increase in osteopathic medical schools. As a result, in the United States, the number of medical students has increased by about 30% in the last decade. And that's in response to the observation that many of the leaders in health policy advocated for growth in medical school as the primary mechanism for increasing the number of physicians caring for patients in the United States. There's some debate amongst experts about whether there's truly a doctor shortage or whether it's rather a geographic maldistribution or a specialty maldistribution. But that's a controversy that we'll save for another night. But suffice it to say that over the last decade, most of the medical education community has accepted the fact that a modest increase in physicians is needed in the United States, and the medical schools have very much done their part. It was, I think, a little unexpected that there would be so much growth in the osteopathic community, but it's been very successful. And in fact, one of the newest developments that I'll talk about later in the talk is that students now of osteopathic medical schools can also enter traditional, fully accredited residency and fellowship programs, the same as traditional medical students. That's relatively new. In years past, the osteopathic medical students trained in their own osteopathic type residencies and fellowships. But everyone goes through medical school, all of our medical students, and that's what we again call UME, or undergraduate medical education. And the conversations up to this point about admissions, about our changes in our undergraduate curriculum, in well-being among medical students, and next week a simulation, and next week a terrific talk on the role of the medical students working with community, are all been mostly related to the work of our UME, our medical student community. But around here, and in most places nationally, we think of medical education as a continuum that begins with UME, but then goes to GME, which is graduate medical education, the residency and fellowship period, and continuing medical education. And so I meet regularly with all the people you've met through the course, Dr. Lucy, Dr. Jones, Dr. Davis, and others, Dr. Wafsi, Dr. Hauer, and we meet as a team on a regular basis to coordinate what happens with the medical students very carefully with what happens with the residents and fellows and faculty. So we think of it all as one medical education challenge and portfolio of work. But after medical school, the students typically go through what they call the match. That's a process by which you put in your preferential choice of specialty, and within each specialty, a number of programs that you would accept, that you would attend if accepted. And typically the students, depending on the specialty, may rank as many as 80 different programs. Others may do as few as 15 or 20. But the average now this year is about 50 programs per medical student as they try to get into, especially some of the most competitive specialties and most competitive programs around the country. And then they enter either here at UCSF. About a third of our medical students stay here for their residency training, and 2/3 will go elsewhere. About half of those stay in California, and then about a quarter or a third will go to programs all around the United States. Residency is an old term. It derives, I think, from an even older term, or at least the phenomenon of an older term, which was called house staff. So you'll often hear people talk about the house staff, which is slang for residency and or fellowship. And the logic of that was the residents back in the day started at Johns Hopkins in the early part of the 20th century, and the residents were pretty uniformly single men who lived in the hospital, or therefore lived in the house, and they were the people, the doctors who helped staff the hospital at the day and particularly at night. And so that lingo of house staff derives from that early history. The word residency has similar derivation, I think, because, again, people were working so hard back in the day where you were virtually a resident, if you would, of the facility in which you were working. Residents these days, through some of the requirements I'll review, work a maximum of 80 hours per week. But in the days of the early programs at Johns Hopkins, it was a full-time job with rarely a day off. In my era, people worked 110 hours a week. If you got a day off a month, it was a good month. And now it's everyone gets a day off, at least one day off a week. It's 80 hours maximum, and there's a tremendous attention to the impact of hours on not only patient safety, but also the well-being of the residents themselves. After you complete a residency, and in any one of roughly 26, 27 specialties, you sit for a board examination, and it's an examination that's written by the specialty that you are trying to join. And so this is a very much of an insider's game, if you will. And I'll give you several examples of it, but the requirements of the training itself and the requirements to become certified in that specialty are driven by that specialty. And so there is some oversight across specialties that I'll go into, but a lot of the essence of the training, of how many procedures you have to do, how many patients of what type or another you have to see, are driven by the specialty itself. The specialties also control how many of a given type of physician there will be. So there's no centralized mechanism in the United States to determine that we might need more neurological surgeons. If we decide somehow, because it's hard, no one is really collecting that data carefully, at least not in the federal system anymore. But if it was decided that we needed more of a given specialty, it would still be up to that specialty itself through various mechanisms to decide to expand training either in existing programs or start new programs. And again, I'll say more about that. But when we talk about the first board, that means after medical school, you study for a test. After typically 3 or 4 or 5 years of training, you sit for your exam, and then you can be a board certified X X being any one of 27 specialties. Most of those specialties then divvy themselves up further. So there are 27 core specialties, but there are about 150 different ways you can be a certified physician in the United States right now. That is to say, in addition to the 27 core specialties or residencies, there are 123 or so, or 120 or so, types of accredited fellowships. That is what we call a subspecialty of a given specialty, and I'll give you some examples in a minute. Now, in addition to those fellowships, we don't have all 125 or 127 at UCSF of the fellowships. We do, I'll show you the numbers in a bit, but we have about 65 of the potential 120. Many of them overlap, so it's not that we're missing a lot of things, but just that we're coming at it in slightly different angles in some instances. However, in addition to the number of accredited fellowships that we have and exist nationally, there are also new fellowships that are being initiated all the time. So there are additional advanced fellowships, at the end of which additional training, you do not sit for an exam, because that's newest of the advanced specialties may not yet be certified as a newest specialty. And I'll show you some examples of that. But the fellowship, the accredited fellowships serve as your second board. And in most specialties now, it's routine after the residency to go and do a subspecialty fellowship. There are some notable examples to that. Family medicine is the most important example, where the vast majority of graduates don't do a subspecialty fellowship. But even family medicine now has several options for subspecialization. Internal medicine has a very large community of generalists, people who have completed their residency and not done a fellowship, but there are 20 different fellowships in internal medicine. And again, nationally, well over 2/3 of internal medicine graduates will also go into a specialty. And pediatrics is quite similar. Again, a dozen and a half or so different specialties with a large percentage of graduates going into one. So in summary, you go to medical school, you take a variety of tests to pass through that. You get your medical degree, MD in the majority of cases, or DO in the osteopathic examples. You then match into a residency, which may mean you have to pick up and move to another city and deal with family issues, housing issues, and the like. Take a second exam, become board certified, and then decide whether you want to continue on for a subspecialty, which also requires anywhere from 1 to 3 years of fellowship and another examination. And then you can start your practice, either joining a faculty position in a place like here, or in most cases, a community practice. And the arrow then also reflects that after this formal graduate medical education training is when the CME, or continuing medical education, or lifelong learning part of training begins. Here's a list of the specialties of medicine. I think I got them all. Some of them overlap depending on whether you count by how they're organized in certification or how they're organized by residency. The numbers come up a little bit different. For example, psychiatry and neurology are served by a single board, but have unique and quite distinct residency training programs. And their own specialties, subspecialties and the like, and their own departments in big academic medical centers. But historically, they came at it as a single board, for example, and certification examination. And ironically, I think now, as we learn more about the brain and how the brain works, after many years of really separating, I think in many respects, certainly on the scientific level, if not yet the clinical levels, they're really coming back together. But you can see it ranges from things that are very common and part of everyday medical practice, such as family medicine, OBGYN, various surgical subspecialties, including general surgery and plastic surgery, neurologic surgery and otolaryngology, orthopedic surgery, each of which are their own individual specialty. And then there are some rather unique ones that you might not have thought about. For example, colon and rectal surgery is its own training pathway. Medical genetics and genomics is a relatively newer field, but has its own pathway to training, and so on. Preventive medicine is a unique in its own way of training, again, with focuses either on general preventive medicine or occupational medicine or aerospace medicine. So all of these are the unique ways that one trains. But one does one of these 26 or 27 first, and then decides to go second into one of the additional 120 or so subspecialties. And these are some of the examples of the subspecialties, just to put them in a frame of reference. As I mentioned, internal medicine has 20 subspecialties, but they're common things that you would think about as part of your own medical care: a cardiologist or a rheumatologist or a cancer specialist, an oncologist. But again, a full list of at least nearly 24 specialties. And the same is true with pediatrics and the like. Ophthalmology has several specialties, but they're not certified. You don't sit for your own examination, but we still consider them subspecialties. And the same is true for neurologic surgery. There are some ways you can subspecialize, but they're not yet accredited. But you can predict, based on the pattern, that almost everything that's on this list that's not yet accredited will be accredited in the next decade or so. So the typical pattern is, as medical science and medical practice advances, people develop new expertise. There's an initial cohort of subspecialists with that particular expertise. And as time passes, they train additional colleagues and eventually form a specialty society. And then eventually, this takes years, appeal to the board and say, we want to be our own specialty. And that's another process, takes variably from 5 to 10 years. And people then will write an examination and create a new subspecialty. On the other hand, there are other things that that are subspecialties or reflect a unique medical practice, but are not a board-certified subspecialty. So, for example, in my field, I'm a general internal medicine specialist. I practice predominantly in the outpatient setting, in the ambulatory setting, as a primary care general internist. I do some teaching in the hospital, but I'm not an inpatient specialist. And when I was training, there was no difference. You were a general internist, and you took care of general adult patients wherever you saw them, whether that was at home or in the clinic or in the hospital or the nursing home, et cetera. And that's not true anymore. So now we have trained a very large group in our fastest growing specialty of hospital medicine, which are general internists, but they spend all of their practice time in the hospital. So that's a different type of example where a very large specialty is split in two, but has decided not yet to distinctively, separately certify themselves. So it allows people to move back and forth more easily between those fields if one wants to. So as long as I can maintain my skills and competence and my hospital privileges, as a general internist, I can practice in the hospital. And similarly, our inpatient specialists, if for whatever reason they choose to practice more in the ambulatory setting, they can do that. So what exactly is a resident or fellow? And you would think this would be easy. We have about 1,500 of them here. I'm basically oversee the people who oversee them, and I'm responsible for many aspects of their training and day-to-day life. But it's very hard to put your finger on exactly what a resident or fellow is, because their day-to-day work or experience is so diverse. And so in the course of a given day or a given week or month, a resident may perform many different roles. And so if you come into the hospital, first and foremost, if you came in through the emergency department or the clinic, you'd meet non-professional staff and then professional staff, nursing staff and the like. But one of the very first people you would meet would be a resident, who would be an emergency room resident or an internal medicine resident or a surgery resident and so forth. So first and foremost, they're a physician. They're doctors. They have an MD degree. What's interesting, though, is they don't have a license. In California, you need to complete a year of training before you are a licensed physician. So even though they have an MD degree and can call themselves doctor, they cannot practice independently. They don't have a medical license. It's a little bit more complicated than that because as long as they're in a training program, they can't practice independently then either until they complete their full training program. So through every minute of their work, they must be supervised. And we'll come back to that and talk about some of the different levels of supervision. So they're medical school graduates, either MD or DO. They're physicians for the first year or two unlicensed and then licensed. Of note, California is about to change in a year and a half or so its requirements for licensure of physicians. Many states, in fact, most states of the United States require 2 or 3 years of training before you become a licensed physician. California only requires 1. The California Medical Board has recently, in conjunction with the state legislature, passed new rules, new laws that will go into effect, I think, in January of 2019, I think, that to become a licensed physician, you will need 3 years of training. So that will change the system very dramatically. So currently, you can do 1 year of training, perform relatively marginally, say, that your supervisors think, well, you know, passing but not great, quit after completing 1 year, say, of 3 or 4, take your licensing examination and hang a shingle and practice medicine in California. And that's what the California Medical Board is trying to prevent, so that in the spirit of patient safety, which is how the Medical Board defines its primary purpose as a consumer protection agency, the feeling now is that doctors need to have more training before they can practice independently. So in the future, it'll be 3 years of training in California, as it is in most states. They're a care provider. They're a member of a team. They work very closely with nurses and pharmacists and physical therapists and nutritionists and other professional and non-professional staff. But at the same time, they're learners. They're always learning. They're always working to meet learning objectives, program requirements, and to obtain new knowledge, new skills, new competencies, as we say in medical education. They're also scholars. They are often doing research or participating in scholarly quality improvement projects. They're also key to our teaching program. So all of our medical students get their primary day-to-day teaching from residents. This is what we call near-peer education. So the residents, even though themselves are very actively learning, are also expected to share what they've already learned with the medical students of all levels. And that's true in all of our specialties. They're often very strong patient advocates, and they often have very strong community commitments and advocacy. And so often in the hospital, people often say, why would I go to a teaching hospital when I can go to a hospital without residents? Are they just practicing on me? Or why should I be there if they're learning? The first thing to say is that they're always very carefully supervised. And there are different levels of supervision depending on the clinical circumstance and the competence of the resident that we're supervising. But in addition, there are 1,500 residents and fellows in our system. That's 3,000 additional eyes in which to see what's going on in terms of patient quality, patient safety, equity, cost effectiveness, and the like, and 3,000 extra hands to help care for the patients in a spirit which, much like nursing, is really very much at the bedside and very much patient-centered. So this creates a lot of very interesting tensions in medical education and especially in residency education. In any given day, am I a learner or am I caring for the patient? Well, the answer is both. It's very hard to differentiate those. We certainly set aside time for all of our residents to sit in a classroom and think through clinical issues and scientific issues and healthcare policy and the like, and quality improvement issues, as our medical students do. And so the didactic learning that one would expect in a classroom like this or a medical school classroom continues throughout residency, and that's required, and we do it regularly. So most of our residents in particular take about a half day a week or every other week to sit down with professors and go through a design curriculum that's been developed by the specialty. But again, as we've been suggesting, many of the other hours of the week, they're working directly with patients. And whether that's service or education is also a bit of a tension and a dialectic process, if you will, because they are providing service, but they're also learning, because caring for every patient provides opportunities to learn something new. Another way to frame this in the context of labor law and in terms of healthcare law is, are they students or are they employees? The state of California has ruled that, in fact, they, for the purposes of labor representation, they're employees. And in many instances, including parts of UCSF, residents and fellows are in a collective bargaining agreement. Organizations and unions, much like our nurses are and other professional and non-professional staff. That's not the majority of cases around the country, but it's not new. It's been true at least for 40-plus years that residents in different settings, particularly on both coasts, have organized as a way to both push for greater improved service for patients, especially in the early days of resident unions, and now continuing to work on that kind of patient safety and quality improvement issues and the quality of care, but also issues related to the quality of life-work balance, well-being, and the like. And the other tension or dialectic in residency training is this tension between supervision versus autonomy. As I mentioned, no matter how long the training program is, for every day that they're in an official accredited training program, they're supervised. But the day they leave, they're an independent practitioner. Now, life doesn't work that way. You can't just go from being supervised, and then the next day be expected to practice independently. So we have this process we call graded responsibility, which means that throughout the process of training, residents and fellows, as they pass through their various competencies, or we call milestones, that is, targets to show that they can practice in certain parts of clinical care independently, we can change the type of supervision. So we have what we call direct supervision, which is when I'm right at the elbow with a resident. So if we're taking out a cataract, I'm there, she's here, and we're doing it together. And if it's a 10-step process, I let her do step number 1, and then I do 2 through 10. And then I watch her the next day, and she does number 1 again, and she does number 1 until I'm confident she can do number 1. And then we go ahead and do number 2, and then I do 3 through 10. And that's direct supervision. We're together, elbow at elbow, and we do a lot of that. All of our first-year residents have direct supervision. and certainly almost all of our procedural specialists have a lot of direct supervision. But there's also what we call indirect supervision. That's a case where, as residents have proven that they can practice independently by repeated performance and assessment. We let them practice independently in certain functions, but there might be a supervising physician in the hospital, say, for example, or in the office, who's available to consult in a very rapid frame of reference. And then there's more remote indirect supervision, where, for example, my resident might be in the hospital and I might be at home, but we speak at 10 o'clock at night, and then as he or she is working independently through the evening, they'll call me if there are issues that they need assistance with overnight, or they'll consult another physician who's in the hospital overnight. And then at 7 o'clock in the morning, we'll meet, see the patients together, and move into more direct supervision. Now I can again see directly the way they're connecting with the patient, examining the patient, and the like. So it's a mixture of direct and different types of indirect supervision. But they're always supervised. The attending physician is always the responsible party, whether that's true for medical legal issues, informed consent, billing issues, and so forth. It's always the faculty, in our case, or the attending physician who's responsible. But again, we have this graded responsibility so that as they go through their 3 or 5 or 7 years of training, depending on the specialty, they get progressive autonomy so that by the time they finish, and that they can hang a shingle and practice independently. So it's a fascinating process trying to figure out exactly how much rope is enough. How loose do you want to keep that rope to keep people linked in, but also allowing them to develop autonomy. So it's a fascinating process. As I mentioned, here at UCSF, we're about the 7th biggest training institution in the country. And that includes some that merged, so for example, Cornell and Columbia merged, so they're bigger than we are now, even though we were bigger when they were separate. But for example, if there are about 130,000 residents, accredited residents in the United States, and if you think about it, since we have about 1,300 accredited residents and fellows, UCSF at any given time is training 1% of the doctors in training in the United States. That's pretty amazing when you think about it that way. There are about 800 teaching hospitals. About 150 of them are primarily affiliated with the medical schools, of which there are about just under 150. But then there are another 650 teaching hospitals that either are affiliated with the medical school or independent, and through their own auspices can sponsor residency training as well. Here we have the school be in charge of that process. That's true for about half the medical schools. That is where the school stays in charge. The other half have the hospital be in charge. We're very proud of the fact that we have the school in charge for the reason that I discussed before, that medical education is a continuum. And so we want to make sure that there's coordination between the different phases of medical education. And as I like to say, there's an E in GME that stands for education, and therefore being in a school of medicine rather than a hospital per se is advantageous, we believe, for our training. In addition, it's important for us because we don't just have one hospital. I'll show you some pictures in a minute, but our residents work throughout San Francisco. We like to say we're one great university and one great city, but we're spread all over the place. My parking pass allows me to park in 22 different lots in San Francisco that are UCSF parking lots, many of which are places that we see patients. But the VA hospital is very much a part of UCSF, and all of the faculty, all the physicians at the VA, minus just a small, very small handful, are UCSF faculty, the same as the physicians at UCSF Health, which is what we now call the system here. And at Zuckerberg San Francisco General, also all of them are full-time UCSF faculty. The nurses and professional staff are not necessarily. There are some in each instance who are connected through our nursing school and have faculty appointments, but then in addition there are nurses who are independent and employed by the city and county or the university or the Veterans Administration. As I mentioned in green, we also have a large number of fellowships waiting to happen, if you will. They're happening, but they're not accredited yet. And some of these are specialties that will be developed in the future, like some of the things I mentioned on one of the earlier slides. And others are people, it's an artificially inflated number a little bit because, for example, to be a resident, a fellow in, say, for example, pulmonary and critical care medicine at UCSF, it's typically, by rule, it's a 3-year program. You need 3 years to take your board examination. But our program prides itself on training people for academic pulmonary and critical care medicine, and therefore almost everyone does a 4th year. And that 4th year is a research year. So technically there's still, or practically speaking, there's still a pulmonary and critical care fellow, but we call them a non-ACGME, a non-accredited fellow, because they're doing research that last year. And these are just some pictures of some of our sites. In the middle is the buildings we're nearby, just about in here on this campus, but also our new hospital in the upper right at Mission Bay, our UCSF Medical Center at Mount Zion, which is increasingly becoming our ambulatory care center. The Children's Hospital at Mission Bay, and the new hospital at Zuckerberg San Francisco General. I could have just as easily shown our Benioff Children's Hospital in Oakland, our Veteran Affairs Hospital, and then really about 4 or 5 dozen other affiliated clinical sites in San Francisco. So we have about 72 accredited sites where we send residents, the most of which are in San Francisco, but we also have a large number of training experiences in the East Bay and the South Bay, Hawaii, Uganda, and so on. So depending on the needs of the learner, we've developed additional residents so that the residents can get different kind of experiences that they may not get here. 15 years ago, for example, at UCSF, we were just barely doing enough normal deliveries to train an OB resident, an obstetric resident. And so in order to get the procedures up on they were getting tons of abnormal deliveries and the most complicated deliveries in the world. But in terms of the routine normal deliveries, that wasn't what our faculty did. And so our residents went to Kaiser Walnut Creek or Kaiser Honolulu or Alta Bates Hospital to get more general obstetric experience. That's no longer the case. We still send them there, but they also get plenty of experience here as our OB program has dramatically increased over the course of the last 5 years or so. But we have partners all over the Bay Area and all over the world, not only for clinical care, but also for training. All right, let me talk a little bit about what I would call quality control. And that's to make sure that not anyone can hang a shingle and say, we're going to hire residents. There's a very strict, some would say tedious process of starting a new residency program. First, you have to figure out how you're going to pay for it. You're going to have to figure out who's going to supervise the residents and fellows, where they're going to get adequate clinical exposure that meets the requirements of that specialty, and then attract good residents to the program, keep them there, and meet all the program requirements and so on. And so back about 50 plus years or so, the professional societies, the Hospital Association and the Medical School Association and the AMA and the Physician Association and others came together and said, we need to contribute resources to start an entity that can help accredit our residency and fellowship programs. And that entity exists. They're an independent organization with a board of directors and so on, called the Accreditation Council for Graduate Medical Education, or the ACGME, and you'll see that abbreviation. And that's analogous to what happens to our medical school. So Catherine probably spoke about the LCME, which is an analogous process by which the AMA and the medical schools came together decades ago to create the standards by which medical schools will be accredited. And the analogous process is true for GME, Graduate Medical Education, and as I'll show you in a moment, the same is true for CME in an analogous manner. But the ACGME comes together and has each specialty. In the old days, decades ago, the specialties created systems whereby they themselves regulated their specialty, as I implied earlier. But they have been brought together under the umbrella of the ACGME. And so the specialties still have their own, what we call residency review committees. It's very similar to the list I showed you before of all the specialties. So there are about 27 of them. And they create the program requirements for each specialty. In addition, however, there's a set of what we call common requirements that is essential skills that all physicians must have. Those are called the common requirements, and they're true for all specialties, no matter if you're a family physician, an ophthalmologist, or a neurologic surgeon. Everyone has to meet those requirements. And that has to do with things of the basic competencies related to communication skills, professionalism, what we call practice-based learning and improvement, and systems-based practice, some general principles of doctoring that are independent of the specialty. But then the specific knowledge and patient care skills required for each specialty are then developed by the specialties themselves. And then overlying that are what we call institutional requirements, which are determined by the ACGME, that we as a sponsoring institution, in our case the school, in many other places the hospital, are obligated or committed as a sponsoring institution to fulfill. And that includes things having to do with the working conditions, the clinical learning environment, having adequate call rooms, food, other professional and non-professional staff, making sure that the residents are doing the work of a physician and not the work of a non-physician. Resident well-being, how many hours residents can work, what the quality of supervision is, what the infrastructure is, what the salaries or how salaries are managed. Those are all issues at the institutional level that we're responsible for in my office. And then the review committees, all 27 of them will then sit down and develop the details of what it takes to be whatever the specialty is. And here are, many of the elements that the review committees think about. How long should training be? How many trainees should there be in a given specialty? What's the learning objectives? Who else needs to be there? How do you monitor for well-being, evaluation and assessment, and so on? And then we, as the institution, are responsible for making sure that there's quality control of each of the programs. So my team is in charge with overseeing our 92 accredited programs. Each program then has its own program director who's responsible more directly for meeting the program requirements and supervising or setting up the supervision of the residents and assessing them individually one by one, and also making sure there's adequate program quality. And at the end of the day, the program director signs off on each resident and says he or she is qualified to sit for the examination in our field. We have oversight by the national accreditor, oversight by each sponsoring institution, oversight by each program director, and then requirements as carried out by each resident and each supervisor. Now, what's some of the things that are new in the last decade or so are greater responsibilities and definition of roles for faculty. There's been a lot of interest in work hours, what we used to call duty hours, and a lot of interest now in what we call the learning environment or the clinical learning environment. And I'll touch on several of those. But the issue of work hours, as I mentioned earlier, has been a very interesting historical story. As I mentioned, in the old days, there was no limit. In my era, there was no written limit, but there was sort of a max because people no longer lived in the hospital. There were no longer facilities. So people worked 100, 110 hours a week. And then in 2003, the ACGME and the residency review committees agreed that there would be a limit that residents can only work 80 hours a week. Now, that sounds like a lot when most of us work, at least most people work 40 hours a week. Most faculty work about 55 or 60 hours a week. But practicing physicians also work at least 60 plus hours a week, depending on the setting. But 80 is still a big number. And there have been a lot of debate about that, because the question is that enough time to get all the experience you need in the number of years assigned to that specialty, or is it still too much? What we know is that when people are awake for more than 16, 17 hours without rest, they have the cognitive skills of someone with a blood alcohol level of 0.08, right? And no one wants a drunk doctor. So that's sort of been the concern that people have had, saying, well, people shouldn't work more than 16 hours without a break. However, others would argue, well, patients come in, if the patients come in at 8 o'clock at night and you spend a couple hours getting them initially cared for, and then I have to go home, I'm going to miss what happens all night. I'm going to miss that operation. I'm going to miss when they get sick and need to go to the intensive care unit. I'm going to miss seeing them get well overnight. Then I'm going to have to come back in the next morning and figure out what happened all night and get a handoff, as we call it, or transition of care. And so there are definitely two schools of thought about this, and there's no single consensus. The procedural specialties in general have wanted longer shifts because surgical patients and cases often evolve over the course of 24 hours or so. And other specialties, like the pediatricians, have felt very strongly that there should be a day team and a night team, and you shouldn't work longer than 16 hours. In 2011, the pendulum swung, and the 16-hour people won. And the way it was played out was that interns, at least, people during their first year of training, couldn't work more than 16 hours consecutively. Then there were also strict limits about break times and days off and the like. Second residents and beyond were allowed to work longer shifts, the maximum being 28 hours. So 24 hours of direct service and 4 additional hours of transitions of care. That used to be 30 hours back a decade or so ago. In 2017, though, it changed again, and the pendulum swung back. There were a couple of big studies that compared 16-hour shifts versus the 28-hour shifts, and were not able to show that care was safer with one of the systems over another. The residents preferred the 16-hour shift in terms of their well-being, but there was no patient care differences and no significant learning differences. So right now, we're back to a period of flexibility. So some of our specialties work 28-hour shifts and then get more days off. Others work 16-hour shifts, and different residents prefer, and different programs prefer one or the other. The ACGME works with us very closely. We submit data to them every year to show them how we're doing. And it's an accreditation cycle, as we suggest and shown here, whereby it's this continuous improvement where we send in our outcomes every year. I'll show you what they are in a minute. We identify areas that we want to work on to improve. We assess how those improvements are going, and then we measure the data again. In quality, there's a classic quality improvement cycle, what we call Plan, Do, Study, Act, or a PDSA cycle, but it's now in an educational context rather than a clinical context. But the idea is to guarantee continuous improvement, to maintain quality, and to promote innovation. And so the ACGME will review for each of our 92 programs every year their data and give them an accreditation status, and I'll show you what that looks like in the next slide or two. And in addition, if things aren't going well with the outcomes, they'll send us a letter and say, you're still accredited, but here are the things that were so-called citations. Here are the things we want you to work on. And here is another list of things we think you should be working on just for continued improvement. If things don't improve, then they'll come and come and visit. And the purpose of the visit is really to assess how things are going with firsthand validation of the data. And one of the most important pieces of data are conversations with the residents themselves. So each year the residents are surveyed, describe how their experience is going, and that resident perception, and resident and fellow perception of their training is one of the most sensitive drivers of our program's accreditation success. So making sure that the residents are meeting their learning objectives and including adequate well-being, safety, and the like is the primary determinant of accreditation. In addition, each program gets visited every 10 years routinely. It used to be every 5 years, so this is meant to be a more liberalization of the visits. But the price we have to pay now is annual data submission. So it used to be they came every 5 years. If you did well, see you in 5 more. If you didn't do quite so well, you got 4 years, but it still wasn't so bad. But now every year we have to submit data. So instead of one giant pack of data, it's a smaller pack, but it's annual. In addition, they come and look at the institution every year, every 10 years. And a new program that was started about 5 or 6 years ago is called the Clinical Learning Environment Review, where a different type of team of visitors come, not so much educationally oriented, but focus on what we call the clinical learning environment, looking to see what the setting is that the residents learn. It's been shown in several studies that the quality of care provided by the institution in which you train as a resident or fellow predicts to a large extent your own quality data 30 and 40 years into your career. So for example, if one looks at obstetric outcomes in Florida and New York, this is how these studies were done, for example, they were able to correlate all clinicians got better in terms of quality and safety as they matured throughout their career and with lifelong learning and experience. But there was a difference in quality between the groups of physicians, and about half of that difference was predicted by where they trained. And so that's now been validated, having to do with the costs of care and also the safety of patient care and the like. And so in response to that, the ACGME created a different type of visit, not so much educators or the subspecialists, but now quality improvement nurses and institutional leaders and chief quality officers who come and visit each setting, much like our hospitals are accredited, but now with an eye on issues like quality and safety, professionalism, supervision, work hours, and transitions of care. Those are the 6 themes. And so very different than looking to see if the programs are each one by one meeting their program requirements. In addition to that, we have to make sure that the settings to which we send the residents are practicing medicine at the highest quality in the safest way possible with terrific supervision, professionalism, and transitions of care. So there's a lot to do, which is why I have a job. Here are 8 elements that we submit to our residency review committees on an annual basis. And these are ways in which we are judged and our accreditation status for each of 92 programs is determined each year. Are people dropping out? That's program attrition. Is the leadership changing all the time? Do the faculty and the residents and fellows contribute to in a scholarly manner to research? Do they pass their boards, whatever the specialty is? And we work with the certifying boards to get that data. Do they see enough patients of a certain type? Do they document that they've done this procedure the required numbers of times? And then are the faculty satisfied with their work? And are the residents satisfied with their work? The last one, milestone reporting, is an assessment strategy by which each program must report the progress of each resident over time, marching through certain milestones, if you will, of competence. Markers of how their skills are developing on a trajectory to be fully competent at the time that they finish the training program. But you can see in a place like ours, where our faculty do a lot of research. We have a fairly stable group of faculty. It's a selective, desirable place to train. We don't get a lot of dropouts. We have plenty of patients that we care for. People pass their boards. Our faculty are pretty happy. You can see that the one variable that most predicts how a given program is going to do is the resident and fellow survey. And so this is this very ironic observation that learner satisfaction, which I'll show you in a couple of slides, is a relatively low level to assess the quality of an educational program. And I'll show you that in a different context in a minute. But yet that metric, how satisfied are the residents and fellows with their training program, and it predicts the accreditation success of a given program. Now, there is a global question, would you come back to this training program? That's one of the metrics. But there are also very detailed questions about work hours, supervision, the learning environment, being able to speak freely, adequate patient experiences, and the like. But it's really the resident feedback that really predicts how people get accredited. And this are the general categories of accreditation. There's nothing too much to focus on here, but if in most of our programs, almost all the programs nationally are green, that means they're accredited annually, and so we get notices every year, and either with some citations or preferably without any. Unfortunately, we get very few citations, and the vast majority of our programs do great. But now and again, something happens. We had one program where it's a very small program with a very small number of faculty. 2 or 3 of them left the same year, and all of a sudden the program was in serious trouble. And so that program gets an accreditation with warning or can go on probation. Probation is very uncommon. And it is not the ACGME's intention ever to close a program. As I mentioned, most experts, not all, but most experts believe that there's not enough residency positions to train enough physicians in the United States. So no one's interested in closing programs, but everyone is interested in maintaining high quality. And so, but we do quite well in this regard, but it certainly keeps us on our toes because it can go bad quickly if something related to the patient mix, the clinical setting, the culture, faculty, and so forth change within a program. I just wanted to show this slide. I'm not going to read the whole thing, but you know, as we think about the principles of training residents and fellows, as I mentioned, sort of as we like to jokingly say, in the days of giants, you know, back in the day when we gray-hairs were training, we didn't think about principles of training. We just showed up each morning and did what we were told to do. And if you saw a faculty, that was great. But if you didn't, you worked with your senior resident and got through the day and took care of patients best you could. Now we've completely changed our philosophy and our aspirations as to how we should train are really extraordinarily high and very patient-centered and learner-centered. And what's interesting is, although everyone at UCSF would say our first mission is patient care, excellence in the quality of care of today's patients is unequivocally our #1 goal at UCSF. But interestingly, a second principle that tied for first, if you will, is excellence in the quality of care of patients cared for today's residents in the future. So we feel responsible for those 40 years of practice that each of our graduates will do throughout their career. And so it's this very interesting tension. Another tug of war I could have shown is that tension between education and service, but also the tension between patient care and education. The constantly balancing both of those, which are always taking place together. And some of the other language is really quite interesting. The joy of curiosity, intellectual rigor and discovery. I mean, those are pretty high principles and the ones we aspire to. Let me just spend a minute talking about financing of graduate medical education. This is an issue, this is now moving into health policy. This is the only slide I'm going to show in this regard, but it's increasingly relevant, certainly this week. If you follow this process in Congress, which I know you don't, for the most part, no one does, but it's been an issue that's been quite quiet the last several years. But whenever you hear anyone talk about changes to Medicare, embedded in that conversation are changes to the training of physicians. And the reason for that is that most residents and fellows in the United States are paid through the Medicare Trust Fund. And this is something the federal government initiated several decades ago. It's, as you know, the Trust Fund Medicare program is an entitlement. It's not an annual expenditure. So it's not something that the Congress negotiates on a year-by-year basis as part of the budget, but as part of our entitlement system funded through, like Social Security, through a Social Security fund, or in this case, a Medicare Trust Fund. And so each month, we have staff who report to the federal government, to the people who run Medicare, how many residents we have, what they've been doing, like which hospital, which health system are they working that month, how much time was spent on research, how much time was spent in conference, and so forth. And we then submit a voucher, a bill, if you will, to the Medicare, who then reimburse us for salary and benefits and overhead of training the residents. In addition, that covers about 1/3 of the money flow. In addition, Medicare years ago figured, well, hospitals who are training residents are going to be less efficient than hospitals who aren't training residents. They're going to need more beds. They need call rooms. They're going to need more nurses. They're going to need more faculty doing supervision. They're going to have to feed people and provide uniforms and so forth. And the process of running programs and supervising residents creates additional costs. In the early days, there was also increased testing, increased expenses related to training. That's no longer very much the case anymore. But nonetheless, in the old system, Medicare pays teaching hospitals more per patient than a non-teaching hospital to cover for the extra expenses the hospital gets for training residents. So that's called indirect medical education. The salary and benefits is called direct medical education. That distinction is a little esoteric, but the bottom line is that Medicare pays for the vast majority of residents in the United States. Now, in 1997, Medicare said enough. We're only going to pay the amount you have right now, and any growth that happens in the, after 1997, you're on your own. And so so all the teaching hospitals have a cap on Medicare. So although the theory is that Medicare pays the predominant portion of resident training, the teaching hospitals themselves also pay a very large amount. But the largest amount is from Medicare. Now, in 41 states, Medi-Cal also, or Medicaid also pays for training, not in California. There are some training grants that support some professional fees, extra revenues that the departments get from caring for patients, sometimes donors, and the military sometimes asks us to train people on their behalf. But the vast majority of funding comes from the federal government. The point of this paragraph is that whenever there's a conversation in Washington about entitlements, debt ceiling, or in this case, tax changes that will theoretically impact the Medicare trust fund or Medicare payments, that is code, at least in part, to a cut in resident and fellow training and a reduction in training of doctors. Now, big places like UCSF, if we got cut Medicare dollars, we would have to think about it. But probably we would continue to do most of, if not all of the training that we do, because we find it a very efficient and effective way both to train and to care for patients. But many of the smaller teaching hospitals will say, well, we're not getting paid anymore, we're not going to do this. We'll just hire nurse practitioners or physician assistants or hire some more attendings and get out of this business. And so that's a potential cycle where, because I already told you that we've increased the number of medical students and there's an increasing squeeze on the number of residency slots, and if those get cut further, then we end up graduating medical students with $200,000 in debt and no way for them to become a licensed physician. So this is a very challenging issue, and one that the medical schools and the teaching hospitals, through lobbyists and government officials, pay a very close attention to in Washington. And just a few weeks ago, we have monthly calls about this, and the policy report for this year, and it was true last year as well, is that Medicare has not been an issue. But now with the tax cuts, you can imagine certain scenarios whereby the Medicare fund would be reduced, and it would lead to cuts in entitlement programs. So it's sort of back on the table this month. All right, in the last few minutes, let me go quickly through continuing medical education. As I mentioned, this is basically lifelong learning. It's true same as continuing education in all professions and many, both health professions and non-health professions. But in the context of the physicians, that CME, that medical part, is a specific system that's been created to make sure that physicians continue to learn in a very specific way so that they can continue to get credit. And that credit is required for privileges at your hospital or health system and state licensure. And as I'll show you in a minute, it's also required for maintaining your board certification. So there's a lot of attention to making sure that physicians get enough credit. And it covers all of the it can cover all of the competencies of clinical practice shown here, but in addition, but it's required for those three purposes. In addition, other health professions, in most instances, can take CME and get nursing credit for it, pharmacy credit for it, and so forth. So we work very closely with the other professions, and we offer specialty credit, continuing education credit in almost all of the health professions. And our goal, of course, is interprofessional health professions education, and that's an aspiration. We still do most of our education in silos, but our work increasingly is to figure out ways to make sure that health professions education is coordinated across the specialties. Similarly to the number of residencies, there are a lot of people who can offer CME credit in the United States. It includes almost all the medical schools. And they're accredited, and we are, in this context, accredited by a body analogous to the ACGME, although now called the ACCME, the Accreditation Council for Continuing Medical Education. And they're in the same building as the ACGME in Chicago. They're on the floor or two below. And work closely on the various principles. So many of the competencies that I showed here are derived from the same principles or the same competencies that we expect our residents to fulfill. The idea of continuing education is that practicing physicians will continue to fulfill these throughout their careers. Now, one of the main issues in continuing education is avoiding bias. And there are many types of bias in education. And one can imagine bias with medical students or nursing students or pharmacy students. But the field has advanced most strongly in continuing education. And the reason for this is because of the very active role the pharmaceutical and medical device industry has played in educating physicians and other health professionals over the course of the last 20 years or so. And so a lot of the regulations related to continuing education of health professions is designed to create a firewall between promotion of medications and devices and education of physicians and other health professionals. And so there are a lot of systems created to make sure that we identify potential conflicts of interest and resolve any potential conflicts before we allow people to teach. So we ask all of our teachers to declare all of their financial relationships and all of their families' financial relationships. It's $1 or more. There's no minimum on this. If you have any financial relationships on a speakers bureau for a drug company, et cetera, share patents, own stock, all those kind of issues, serve on advisory boards, do research for the company, all those are potential conflicts. And then we have to work with the faculty and sort out whether it's a conflict that we can resolve or one that we cannot resolve. And if we cannot resolve it, the faculty may not teach, or in most cases, we resolve it. Most at a place like UCSF, most of our faculty have no conflicts, or if they have conflicts, it's mostly because they're doing research on a new pharmaceutical or a new device, or they're on the scientific advisory board of a company. In that instance, we resolve the conflict by asking them not to include any material, certainly nothing from the drug companies, but more importantly, nothing to do with that would overlap with promotion of a given product. So you can't use brand names, you're supposed to use the common names of medications, or in some instances, if the conflict is too deeply aligned, then we'll ask the faculty to speak on a different topic. Something more basic science or pathophysiology rather than therapeutics. So we're very careful, and then to make sure we did it right, we then asked the learners, did they detect any bias in the presentation? So if someone's up there promoting a specific therapy where the guidelines say there are 6 ways to approach this problem, but the speaker is only talking about one of them, and it's the one related to a brand new drug, then the audience will tell us about it. And that might be someone we missed, but we won't miss it twice. And in doing that, we avoid conflict of interest and bias. How does CME work? Well, we see CME as fulfilling a gap. So, for example, we can define in most clinical areas an ideal practice. So we expect 90% of diabetics to be controlled at a certain level. If in our institution that number instead of 90% is only 60%, then we have a gap of 30% of physician performance related to that objective. So we then define that gap and then form a committee of peers, of experts, to try to say, what do we need to do to close that gap? Is it knowledge? Is it some skills? Is it attitudes? Is it a systems issue? And then we teach to whatever is needed, and whether it's knowledge or competence or skills, to close that gap. And that's how continuing medical education is designed. And you can think of that as something you do within our own system. So we do a lot of continuing education for ourselves. And so our weekly grand rounds, our case conferences, our morbidity and mortality conversations, our tumor board conversations are almost all accredited in a way that our faculty and other professional staff can get continuing education credit. But as a big national and international medical school, and we also do a lot of education for the community at large, the community of practicing physicians at large, and that can be both a regional and statewide and a national audience. So we do about 100 courses a year where we bring in physicians from all over the country at UCSF. Fortunately, people like to come to San Francisco, and people like to hear from UCSF, so it's win-win for everyone. But we do over 100 conferences a year to do that. And then we evaluate what we do very carefully. We do a lot of surveys, post-tests, vignettes, direct observation, quality improvement projects, and the like to make sure that we're evaluating what we call learner outcomes. This pyramid, what we call Moore's pyramid, doesn't project well, but it suggests that there's a gradation of intensity, of accuracy, if you will, of effectiveness by which we can evaluate a learning activity. So we measure, did people participate? Did they come? Did they like it? Did they learn something? And those are the lower stages of the pyramid, but then we get into the higher stages of, did they actually learn how to do something, not just to know something, but to know how to do it? And then did they actually do it? And then did patients get better? And then did the community's health get better? And so we can go up the Moore's pyramid with greater and greater confidence that if we're changing what physicians do and having an impact on patient care, and we see that gap as we do another cycle of evaluation, that our gap went from 60% versus 90 to 75% versus 90, then we know that our education may have contributed to closing that gap. And that's one of the highest levels of educational effectiveness. As I mentioned, we do about 100 live courses a year. We also have a large online presence and a lot of local activities. In fact, the original idea of MiniMed was to take advantage of all the work we were doing in continuing medical education and provide that to the community in our own communities here in San Francisco and the Bay Area, and then eventually, as we now do it online, so that non-health professionals can also learn from our faculty with the same kind of expertise that we offer both our students and residents, but also our community and physicians through our CME programs. And finally, I wanted to mention one other term, which is what we call maintenance of certification. So it used to be enough to take CME credits, show that in California you need 25 a year, so it's 50 every 2 years. You have to list what those are, show them to your hospital, for example, for your privileges on an every 2-year basis, and then tell the state, the Medical Board of California, that you have completed those with selective audits. And so you have to be able to, when asked, prove that you've attended your 50 hours. And that's required for hospital privileging and medical licensing. But there's been some concern amongst the specialties, is that enough? And so in the older days, when I trained in internal medicine, after my 3 years of residency, I took an examination. I passed the exam. I was board certified in internal medicine, and I had lifelong privileges to call myself an internist. And that's no longer the case. No one gets lifelong privileges anymore. It's now something that requires recertification every 10 years, and that process is called maintenance of certification. CME is still part of that process. But in addition, there's other work that one has to do, having to do with not only taking a recurrent examination, and there are different ways that different specialties do that, but also engaging in ongoing assessment of one's clinical work. And that traditionally has been looking at my own practice, but increasingly now we can use a quality improvement work that we do together as a reflection to meet the requirements of improvement in medical practice. So we have to maintain our state license and do our CME and do some self-assessments, pass the tests, but in addition, we have to participate in quality improvement activities in order to be recertified every 10 years. And most health systems, not all, but certainly UCSF and most in the Bay Area, require that physicians not only be board certified to be on the medical staff, but also are maintaining their certification in order to stay active. And that's partly why the state has also moved to the 3-year limit, since that's the minimum for many of the residency programs. The idea is that that additional training and maintenance of training is essential. So with that, I'll stop and end with the aspiration that this process of continuous professional development that begins after medical school and continues throughout one's life leads to quality health care, and quality patient experience, what we call the triple aim. So that's our aspiration in medicine and certainly at UCSF. And with that, I'll thank you very much for your attention and take any questions or comments. Thank you. We do have a medical school program at Berkeley. It's called the Joint Medical Program. It's a UCSF program. They spent 3 years at Berkeley. They're UCSF faculty, UCSF students. They take classes at Berkeley and get a master's degree in 3 years and then come into San Francisco for clinical work at one of our 3 main teaching hospitals with the other medical students. So that's our most prominent program there. But we're increasingly aware, especially as many of our other peer institutions have the advantage of an engineering school, a law school, terrific basic science programs, public health schools, that those are things that we have built from scratch at UCSF. So if we hung a shingle at UCSF for a school of public health, we'd be one of the biggest schools of public health in the world. But we don't call ourselves that. But nonetheless, there's a tremendous amount to be gained by collaboration with Berkeley and with the other great institutions in the Bay Area. So we do have combined programs with Berkeley. They're nascent programs. Joint medical program is well established, but other nascent programs, including some basic science. We have a Department of Bioengineering that's shared with Berkeley, that's a Cross-Bay department. We have a shared program in a master's degree in health law with the Hastings School here in the city. So your point is right on target, and it is our goal to develop collaborations wherever we can find them. You know, if you live in the Bay Area over the last couple of decades, you realize how long the bridge is. And sometimes that separation has really served us poorly, because Berkeley is really quite close, and we're all part of the same system. And sometimes it works great, and sometimes it's just challenging. But certainly, our aspiration is to see ourselves all as one system. We've been working much more with the other UC health systems than ever before. So there's now an entity called UC Health, which is an oversight of the five big medical centers that UC owns in Davis, here, Irvine, Los Angeles, and San Diego. And there are systems that we do together. We compare quality data. We all have more or less, with one exception, the same electronic health record. Our deans meet monthly, our CEOs meet monthly, our GME deans meet monthly, our CME deans meet quarterly. So we work collectively. We do CME with the other 5 UCs. We do GME with the other 6 UCs, because Riverside also has a program. And we're always looking for those collaborations. But day to day in the clinical world, it's a closer collaboration with the campuses that have big teaching hospitals. But in the science world, the collaboration is more with Berkeley, and then the aspiration is with the other professional schools, because we would really benefit from an engineering school, a law school, a business school, and the like. So the question is, how does training differ at a community hospital or a more academic medical center type system? And you know, the requirements are exactly the same. And so both programs would be judged by the same group of our peers. So California Pacific has an excellent internal medicine residency program of their own. We have one of our own. We collaborate on certain things. We share electives, share some faculty. Mount Zion used to have a program that was independent. Kaiser has a program that's independent. Highland Hospital has an internal medicine program. There are programs on the peninsula, Stanford, of course, and Santa Clara Valley, Kaiser in the South Bay. So there are many in internal medicine, for example, many programs in the Bay Area. St. Mary's has a program, all of very high quality, and in part privileged by the fact that people want to come to San Francisco. So both at the faculty level and the program level and the learner level, we get very high quality people. So the training is different in the manner in which I described. We would want to measure the quality of each of those settings, and people would be training with the same general sense of requirements, but probably with a different culture leading to different career choices. So more graduates from UCSF internal medicine will go into a subspecialty than would be from a community hospital. More people who train at Kaiser, San Francisco, or Oakland's program would stay in the Kaiser system or stay as a generalist or practice primary care. But the quality of training that has been obtained at each of the sites must be equivalent, because their requirements are the same, and the oversight is the same, and the national certification is the same. So students make those choices all the time. Sometimes they think one is maybe more academic, and they want to do research or scholarship. Another might meet their goal. They might know they want to work in a setting like Kaiser, so let's get started now. Or they might want to work in a safety net facility, so I'll work at Highland Hospital because that's where I want to. That's the patients I want to serve, and students make those choices all the time, and our very best students make a wide variety of choices. So it's not, variety is the spice of life, and they're all highly accredited, well thought of, and with terrific trainees and clinicians from all of them. All right, why don't I stop, and I'll take some additional questions with the lights off, and just thank you again for your attention.